Welcome to this short video presentation on how to apply physiological guidelines in clinical practice. It is important to realize that each fetus is different. They have different background risk factors, they have different compensatory responses, and they have different physiological stress to withstand the stress of uterine contractions. And therefore, it's not surprising that the use of one CTG guideline with set parameters and time limits, it is unlikely to work well during human labor. So physiological CTG guidelines are meant to understand four key principles while interpreting the CTG traces. Firstly, we need to ask ourselves, is this fetus fit to undertake the journey of labor? So we need to exclude pre-existing or chronic hypoxia at the onset of recording. Secondly, we need to find out whether this fetus is responding well to the ongoing uterine contractions. Labor is a very stressful journey. For about 8 to 10 hours, a fetus is exposed to repetitive and sustained contractions which may compress the umbilical cord and transiently cut off uteroplacental oxygenation. Thirdly, we need to find out what is the type of intrapartum hypoxia that we are observing on the CTG trace. And finally, what is the wider clinical picture? So CTG is one of the tools that we use in labor, but what about the environment of the fetus? Is there meconium? Are we using oxytocin to increase the stress of uterine contractions? Is the mum having temperature that's going to increase the metabolic needs of a fetus and to increase oxygen consumption, predisposing a fetus to hypoxic injuries? Is there any evidence of hyperstimulation or hemorrhage? Is the mum having epidural that can predispose to sudden episodes of hypotension? How is the mother's environment? How is the labor progressing so far? What is the rate of progress of labor? Is there any uterine scar that can rupture? Is there any evidence of chorioamnionitis? And what about the fetal size? Too small has problems. Being too large also has its sets of problems. So the first international consensus guidelines on physiological CTG interpretation was developed in conjunction with an international consensus panel of 36 CTG experts from 14 countries. We were very privileged to have Prof. Sir Sabaratnam Arulkumaran, who is a world expert on CTGs, as our special expert reviewer. And this guideline can be freely downloaded at this website. The physiological guidelines is different because there is no normal suspicious pathological. The CTG traces are interpreted according to the features which are suggestive of intrapartum hypoxia. So either you have no hypoxia, or do we have pre-existing or chronic hypoxia, to ask the question, is the fetus fit for labor? Is there any evidence of a gradually evolving hypoxia or subacute hypoxia? The guideline also talks about acute hypoxia, and sometimes we may encounter certain unusual fetal heart rate patterns. So the first question is this fetus fit for labor? Firstly, is the baseline heart rate appropriate for gestational age? So we cannot use an arbitrarily cut off or range between 110 to 160 beats per minute, because that is for a population of human fetuses and not for the individual fetus in question. As the gestation advances, due to the progressive maturation of the parasympathetic or vagal system, the baseline heart rate continues to fall throughout pregnancy, and therefore a fetus at 41 weeks cannot be expected to have a baseline heart rate above 150 beats per minute. Secondly, let's confirm normal variability and cycling, which are hallmarks of good central nervous system oxygenation. In early labor or in the antenatal period, we should have accelerations, and we need to exclude the chemoreceptor mediated shallow or late decelerations, which indicate uteroplacental insufficiency. Finally, let's ask a question: how is this fetus different to other fetuses in the labor ward, by understanding the wider clinical picture. Once we do this checklist and confirm that this fetus is fit for labor, then normally in evolving hypoxias, fetuses show a predictable pattern according to physiological responses to hypoxia. So the first change that you get on the CTG when hypoxia begins is the onset of decelerations. This will be followed by the loss of accelerations as the fetus attempts to conserve somatic body movements. This will be followed by the release of catecholamines to obtain more oxygen from the placenta and also to pump faster to the central organs, and therefore there would be a progressive rise in the baseline heart rate. And the fetus would go into a compensated stress response, where the baby would still maintain a stable baseline fetal heart rate. It doesn't matter the number, 140, 150, 160, but it remains stable. It doesn't fluctuate. It doesn't become wavy and maintains a normal variability. If hypoxia continues beyond that time, depending on the rapidity of onset of hypoxia, the intensity of hypoxia, as well as the fetal responses to hypoxia and the reserves to withstand hypoxia, after some time there would be onset of decompensation, which will be characterized by an unstable baseline and changes in variability. If no action is taken, finally the myocardium would go into anaerobic metabolism, leading to a step-ladder pattern to death. The physiological guidelines have two checklists or stickers. First checklist is to find out, how is this fetus? Is this fetus fit to undertake the journey of labor? The second checklist is to be used every time a CTG trace is analyzed during labor. And this involves comparing what we see now with the initial features on the CTG trace, and to understand whether there is any evidence of intrapartum hypoxia and whether the central organs are well oxygenated, and what are the additional risk factors that have developed during labor. Let's remember that just like any other journey, we need to have a journey planner during labor, the so-called 6 Ps, because all of us want to have a safe vaginal birth, and therefore having a CTG trace and classifying it as normal, suspicious, pathological, using predetermined criteria and arbitrary time limits for all human fetuses is unlikely to be useful. So the first P is the problems, the mothers, the wider clinical picture, whether there is relative uteroplacental insufficiency, or does mom have any complications like preeclampsia, sickle cell acidosis? Parity and the power. Is it a spontaneous labor or an induced or augmented labor? And how has this labor progressing so far? Is it very slow or is it progressing at a good speed? And how is the passenger? The size, position, station, all this will determine the predicted time of birth. How long it's going to take for the labor to end in a safe vaginal birth. And to predict the time of birth, we need to use all our examination findings and the clinical picture. So instead of using normal, suspicious, pathological, physiological guidelines, we will be using the type of hypoxia that we see on the CTG trace. We'll be determining the fetal response to hypoxic stress. How is this fetus? And we'll be considering the clinical picture. And if the CTG is normal and the clinical picture is appropriate, the next question is, how long do we have to continue this labor with the observed features on the CTG trace? Can we do anything to improve fetal oxygenation until the time of birth? So let's go through this case and apply fetal physiological guidelines. So we have a primary gravida who is 40 weeks and 3 days of gestation. She is low risk throughout pregnancy and went into spontaneous onset of labor. And she was attempting a normal birth in a midwifery-led unit. But unfortunately, she was transferred for poor progress of labor. On abdominal examination, this fetus was of average size. The fetal heart rate was 125 beats per minute on intermittent auscultation, and the CTG monitoring was commenced. On vaginal examination, cervix was 8 centimeters dilated, cephalic presentation, the station was +1 station, the fetal head was in a left occipito-posterior position with minimal caput and molding, and the amniotic fluid was clear. So let's first ask ourselves, is this fetus fit to undertake the journey of labor? So this is the starting CTG. So let's use the checklist from the physiological guidelines. Is the baseline fetal heart rate one of 120 beats per minute appropriate for gestational age? Yes, it is. How is the variability, the bandwidth? Is it normal? Do we have any accelerations? Do we have any shallow or late decelerations? And in terms of risk factors, as this labor was progressing slowly, the team was about to start oxytocin augmentation, which is a risk factor. So overall, at this moment, the baby is in a well oxygenated state, so its overall impression is normal. And then in terms of management plan, please remember every labor is different, so we cannot use one guideline in all labors. In this case, the syntocinon or oxytocin is going to be started at 8 centimeters, where you have lots of oxytocin receptors in the uterine fundus. Therefore, we cannot wait for 2 or 4 hours for re-examination, because this myometrium is going to be extremely sensitive to oxytocin. Some hospitals have started using amniotic fluid lactate to determine that the uterus is not tired, because if the uterus has lactate due to excessive contractions, that has resulted in poor progress of labor. Using oxytocin in that situation is not a good idea. In such situations, if the amniotic fluid lactate level is more than 10.1 millimoles, we may have to rest the woman with hydration and start oxytocin after retesting the amniotic fluid lactate. Now let's ask a question. We have started oxytocin, so the fetus is now exposed to increasing hypoxic stress. What would we expect to see on the CTG trace? So in adult life, if you're running, jogging, or if you're in a gym exercising, we increase the rate and depth of respiration to keep our myocardium in a positive aerobic balance. So if you are a fetus who is immersed in water, amniotic fluid, and you have no access to external atmospheric oxygen, the only way you would maintain your myocardium in a positive aerobic balance whenever the stress increases, when your umbilical cord is squeezed or placental blood supply is cut off, is to slow your heart rate by showing decelerations. So this is the CTG before the oxytocin was commenced, and this is the CTG after the oxytocin was commenced. During my CTG master classes, I always tell the delegates, don't call it cardiotocograph because we'll be missing the point. Please call it tochocardiograph because most of the time the changes that we see on the CTG trace are due to strong uterine contractions. So if the oxytocin level is increased and the fetus is going to have worsening hypoxic stress, so what would you expect to see? Just like in the gym, as we go faster and faster, our respiratory rate becomes deeper. In the same way, as the uterine contractions or the hypoxic stress gets worse, you can see here that decelerations are becoming progressively wider and deeper. Let's ask a question, how is this fetus? Because remember, we are not managing the CTG trace, we are managing a human fetus in the journey of labor. So let's use our 50 pence coin to cover the decelerations. And if you don't have a coin, you can use a chocolate. Once we cover the decelerations, let's look in between the deceleration. This fetus is continuing to show a stable baseline fetal heart rate and a reassuring variability. And therefore this fetus is telling us, despite the ongoing stress of repetitive umbilical cord compression characterized by variable decelerations, I am still okay. I am still maintaining oxygenation to the central organs. But please remember, we need to be very careful because this myometrium is very sensitive to oxytocin. And therefore, if we find changes on the CTG, we need to reduce the stress by reducing oxytocin. Please also remember, uterine hyperstimulation is not defined as more than 5 contractions in 10 minutes because uterine contractions have 3 properties: duration, strength, and frequency. Sometimes you might have only 2 contractions, but they are lasting longer and they are stronger. And if you find changes on the CTG, that is uterine hyperstimulation. So when you use prostaglandins or oxytocin, please remember the definition of uterine hyperstimulation is any increase in uterine activity associated. If you see this CTG from a pattern recognition point of view, depending on the inter and intra-observer variation, this may be a suspicious or pathological trace. But let's apply the physiological CTG guideline on this CTG trace. The baseline heart rate is about 120 beats per minute. The variability or the bandwidth is approximately 15 beats per minute. There are no accelerations, and we should not confuse the shoulders and the overshoots of variable decelerations as accelerations. There are decelerations, and these decelerations have a quick drop and a quick rise, indicating that these are variable decelerations due to baroreceptor stimulation. And now let's look at the rise in the baseline. There has not been any catecholamine response because despite the decelerations, the baseline has remained at 120 beats per minute. You could also see the alternative episodes of reduced and normal variability, which is called cycling, and it denotes the active and quiet sleep phases of a healthy fetus. And therefore, the fetus has maintained cycling. There is no abnormal variability. And if you look at the type of hypoxia, we have got the onset of decelerations, and therefore it is a gradually evolving hypoxia as the decelerations are becoming wider and deeper. The fetal central organs are well oxygenated because if you look in between the decelerations, the baseline is stable and the variability is normal. And we have started oxytocin, which is a risk factor for hypoxic stress. Let's look at the intercontraction interval. This is the time available for the fetus to get fresh oxygen from the placenta. Scientific evidence shows that in spontaneous labor, we should be aiming for 90 seconds to prevent desaturation of the fetus. Donald Peebles' team in 1994 published a paper in the British Journal where they showed that if we use oxytocin, this intercontraction interval should be approximately 2.3 minutes. The woman is now fully dilated. The station is at +1 in the left occipito-posterior position, and there was some meconium staining of the amniotic fluid. Now let's go back to physiology of second stage of labor. What happens to the uterus? It contains and develops more myometrial oxytocin receptors. So if you're a fetus, suddenly when you enter second stage of labor, your contractions are going to be stronger, and that's going to reduce your uteroplacental blood flow, and that's going to squeeze your umbilical cord much stronger and longer periods of time. And as your head is being pushed into your mother's bony pelvis, your intracranial pressure increases. Not only that, the distension of the cervix by the fetal head at full dilatation releases oxytocin from the uterine decidua, so-called the Ferguson's reflex. And therefore, we need to be extremely careful about starting oxytocin during second stage of labor when the uterus is maximally sensitive to oxytocin. Especially if the woman has been showing good progress of labor. If you do so, it will be pain. Pain is proactive ignorance and negligence. It is pain because it's painful for a fetus as it increases the risk of hypoxic ischemic injuries. It's painful for the parents, and it is also painful for us obstetricians and midwives because we may have to write statements for risk management process and sometimes go to courts. So let's not start oxytocin in second stage of labor when there is evidence of progress of labor. So let's ask a question. How will this fetus, who is exposed to now excessive oxytocin in second stage of labor, protect the myocardial workload? And if the fetus requires additional oxygen from the placenta, what would you expect to see on the CTG trace? So you can see here the decelerations are getting wider and deeper as the fetus attempts to rest the heart to protect the myocardial workload. And if you look at the baseline heart rate, the fetus has now released catecholamines to increase the blood flow to get more oxygen from the placenta. So if you cover those atypical variable decelerations, which are baroreceptor mediated decelerations, and look in between the decelerations, we could see that the fetus has increased the baseline fetal heart rate due to catecholamine release, but the variability is still normal. If one uses a pattern recognition guideline, this would be classified as a pathological CTG trace. However, it means nothing to the fetus. But if we use physiological CTG guidelines, you are trying to determine the type of stress the fetus is exposed to, the fetal response to that stress, whether the central organs are well oxygenated, and finally, what is causing that stress and what is the wider clinical picture. So if you go back to our physiological guidelines, let's look at the baseline heart rate. This fetus is telling us that there has been a catecholamine response to obtain more oxygenated blood from the placenta and to redistribute it to the vital organs. And the fetus is exposed to repetitive umbilical cord compression because you could see the fetal heart rate abruptly falls and then rises immediately back to the baseline, suggestive of baroreceptor mediated cord compression decelerations. Now if you look at whether the fetus is maintaining good oxygenation to the central organs, not only the variability between the deceleration is normal at this moment, but you could also see the alternative periods of reduced and normal variability. This phenomenon of cycling is very important, and it denotes that despite the stress the fetus is exposed to, the fetus is able to maintain central organ oxygenation. There is no evidence of any abnormal variability. Yes, there is evidence of hypoxia, but if you look at the time spent during the decelerations, they are much longer than the time spent at the baseline to push out the accumulated carbon dioxide and to get fresh oxygen. And therefore, we know that this fetus is exposed to subacute hypoxic pattern. Let's ask a question. Are the central organs well oxygenated? Look in between the decelerations. If you go back to your scientific evidence, in the presence of a normal baseline variability, the risk of acidosis is very low. But we need to immediately help the fetus by modifying the stress, by reducing the oxytocin infusion. In this case, you could see as the catecholamine surge has already occurred and the fetus is going into a subacute hypoxic pattern, it is important to immediately stop the oxytocin infusion to reperfuse the fetal vital organs. On repeat vaginal examination, the cervix is fully dilated. The fetal vertex was in an occipito-posterior position, and there has been some progress as the station has come, the fetal head has come down from +1 to +2 station, and there was caput and molding. Is +1, what would you do? Now, if you are a physiologist, you would first stop the stress because the changes on the CTG are secondary to excessive uterine contractions, which have been induced by oxytocin. But if one is a pattern recognition person, you would classify this CTG as a pathological CTG. But if you ask yourself a question, what is the chance of this baby being acidotic? Look in between the decelerations. The fetus is still showing normal variability because scientific evidence have shown that a pathological CTG trace has a false positive rate of over 99%. But if you look at the variability in between the decelerations, and if it is normal, you could be confident that this baby is not acidotic at the moment. But we need to immediately improve the oxygenation by reducing the stress by stopping oxytocin. So how is this fetus? This fetus is exposed to intrapartum hypoxic stress, but at the moment, the fetus is dealing with the stress. So you can see what would happen to a fetus when the stress continues based on the physiological reserves and the rapidity of onset and intensity of hypoxia. Very soon, the blood supply going through the carotid arteries will get diminished, leading to depression of the central nervous system characterized by reduced baseline variability. Now we were able to show that if you have repetitive or late decelerations, if the baseline variability was normal, none of the fetuses had acidosis. Even if there's a catecholamine surge where the baseline heart rate has gone up, as long as the baseline variability remained normal, there was no evidence of acidosis. It is only when the baseline variability was reduced, approximately 30% of fetuses developed evidence of metabolic acidosis in the umbilical cord at the time of birth. So please look at the CTG trace. Some obstetricians may be tempted to use pattern recognition guidelines and to call it a pathological CTG because the atypical variable decelerations are continuing for 50% of the contractions for 30 minutes. And therefore they may be tempted to take some tubes and cut the skin of the scalp of a fetus. This is because many years ago, it was believed by some obstetricians that the skin of the scalp was very close to the fetal brain, and therefore if you take a sample of blood from the skin of the scalp, it reflects the brain oxygenation. Some believed by doing a fetal blood sampling, they were reducing the cesarean section rate. But in the gym, when you start exercising, the calf muscles develop acidosis. And therefore, if you take a blood sample from a peripheral tissue like muscle or skin, it is going to show acidosis, and that's going to increase the cesarean section rate. And please remember what we learned in anatomy. The blood supply to the human scalp is supplied by external carotid artery, which divides into a frontal and a parietal branch, and the occipital artery supplies the occiput. And therefore, taking a sample from the skin of the vertex, which is squeezed with caput and molding, does not represent central organ oxygenation. In fact, we learnt in the first year neuroanatomy that the blood supply to the brain is from the internal carotid artery, not the external carotid artery that supplies the scalp. So even though the skin of the scalp is close to the brain, taking a blood sample does not reflect the brain. In fact, it doesn't reflect the skin itself, because when someone takes a blood sample from the superficial aspects of the skin blood vessels are very much deeper, in a deeper plane, in the dermis, and therefore even it does not reflect the blood supply of the skin. Approximately 40 years ago, in the high-impact journal called The Lancet, it was shown that fetal scalp is not a good indicator of fetal oxygenation. In fact, there have been 3 separate Cochrane reviews in 2006, 2013, and 2017. All of them have shown that access to fetal blood sampling did not appear to influence any difference in the neonatal seizures or any other outcomes. In fact, this paper from Sweden actually showed that using more than 2 fetal blood sampling doubles your cesarean section rate and operative vaginal delivery rate. And this should not be surprising to anyone who understands basic physiology. This is because when we run, when we jog, we release catecholamines, we divert the blood from the skin to supply the central organs. So if the fetus is in labor for 8 hours, the normal physiological response of a fetus would be to divert the blood from the skin, including the skin of the scalp, to supply the central organs. And therefore, if someone goes and tests the skin, it's going to be acidotic, and therefore this poor woman would have an unnecessary cesarean section. Now, this study we should all be very proud of our trainees. This is the only and the largest multi-center trials from 44 maternity units in the UK. And you can see that the trainees have concluded that as an adjunct tool to CTG, FPS offered limited value to predict neonatal acidemia, low APGAR scores, and admission to neonatal units. In other words, it is useless from a baby's point of view. And if you ask yourself, are we reducing your cesarean section rate? The paper from Sweden has told us it doubles your cesarean section rate. And if you don't believe that, let's look at our own trainee study, which is a multi-center trial. It shows that there has been a 60% increase in operated deliveries for women. So please, next time, before, if anyone is asking you to do a fetal blood sampling, please consider the anatomy, please consider the physiology, please ask yourself, am I testing the brain by cutting the skin of the scalp, although it may appear close to the brain? And always look in between the decelerations and ask yourself, is the baseline variability normal? Then there is no acidosis. And also, please don't forget that fetal blood sampling approximately takes a median time of 18 minutes according to published data in the UK. So in a fetus with subacute hypoxia with catecholamine response, if we attempt a fetal blood sampling, not only it doesn't improve neonatal outcomes, not only it doubles the cesarean section rate, it may also delay delivery, leading to poor outcomes. So all international guidelines now clearly state that in the presence of a stable baseline and a reassuring variability, the risk of acidosis is low. The Physiological CTG guidelines published in 2018 also states the same. The NICE guidelines of 2017 also states that if there is a stable baseline fetal heart rate and a reassuring variability, continue usual care because the risk of acidosis is low. So please don't perform a fetal blood sampling because the CTG is pathological, because if the baseline variability is normal and the baseline is stable, there is no acidosis. Let's apply the physiological CTG guideline in this case. So now we have seen an increase in the baseline heart rate suggestive of catecholamine response. If you look at the variability, it is reduced, therefore the variability is abnormal. The fetus is exposed to hypoxia, and if you look at the time spent at the baseline, which is much shorter than the time spent during decelerations, which have become progressively wider and deeper. And therefore, this is a subacute hypoxia. If you look at the variability in between the decelerations, they are beginning to get reduced. The team here ought to have stopped the oxytocin, but they proceeded with vacuum extraction because of the pathological CTG. We know that the type of hypoxia this fetus is exposed to is subacute hypoxia. And the rate of fall in pH in subacute hypoxia is approximately 0.01 every 2 to 3 minutes. Now let's work out the umbilical cord pH. To do that, let's go to a CTG trace where we could find a segment of normal variability. Because if the baseline variability was normal, the risk of acidosis is low. The pH is somewhere between 7.2 to 7.3. And we know that this fetus was exposed to subacute hypoxia for approximately 10 to 15 minutes. And we know that the rate of fall in pH is 0.01 once in every 2 to 3 minutes. So the pH would have fallen by about 0.1 in 20 to 30 minutes. And therefore the lowest arterial pH you would get is about 7.15. And you can see how, by understanding fetal physiology, we will be able to predict the outcomes. So the physiological CTG guidelines, in conclusion, has a checklist to test whether this fetus is fit for labor. And then each time when a CTG trace is reviewed, we need to find out whether this fetus is compensating well for the ongoing stress, how is the fetus, and what is the type of hypoxia, and what is the wider clinical picture. Finally, let's do some reflection and learning, because one may argue the outcome is good. It is true in this case. But remember, just because the outcome is good, it doesn't mean that our management is good. Conversely, sometimes we may have a poor outcome, but we may have managed the case better. In this case, the team should have reduced the oxytocin infusion once they observed good progress of labor and the woman was in second stage of labor. They were lucky, but we are not always lucky. And remember, starting oxytocin in second stage of labor when there's evidence of progress of labor is pain, is proactive ignorance and negligence. It is pain for the baby. It may cause pain to parents. It can also cause pain to a midwife and obstetrician. And let me finish with this. This is the latest Each Baby Counts report published in March 2020. Unfortunately, we have lost 1,130 babies in England in a year. Out of that, 850 babies have had severe brain injuries. And sadly, 72% of these cases, the report has concluded that different care might have made a difference to the outcome. And CTG interpretation errors contribute to approximately 33% of all cases. And sadly, failure to act upon suspicious or pathological CTG has contributed to 44% of these cases. The problem of pattern recognition guidelines with set time limits such as 30 minutes, 50% of contractions, etc., is that each fetus is different, just like all of us adults, and therefore we cannot use arbitrarily chosen time limits in all fetuses. This was the report in 2015 where 921 babies died or got severely brain damaged during 1 year in labor. 2018 it increased to 1,123 babies, and 2019 it has further increased to 1,130 babies, and sadly 72% of these cases are potentially avoidable. So to conclude, each time when we see a CTG trace, let's first ask a question: is this fetus fit for labor? Then let's use fetal physiology to understand the type of hypoxia and the fetal responses to stress. And let's not forget that CTG is only one part of the puzzle. we need to have an intrapartum journey planner. We need to find out, to achieve safe vaginal birth, let's stop calling it normal, suspicious, pathological. Let's take a step back and look at the speed of labor, the wider clinical picture. Let's work out how long do we have to deliver this baby. Let's not cut the skin of the scalp every hour, because that doesn't help. Use of physiological guidelines would tell you the type of hypoxia, how is this fetus at this given time, and what is the wider clinical picture. And based on what we see on the CTG and based on the wider clinical picture, let's work out how long it's going to take to achieve a safe vaginal birth so that we can take right actions, including to reduce the stress. Thank you very much.